Hi class, thanks for coming back after the wonderful presentations. So I want to talk about two hematological disorders that we commonly see in pediatrics. And the first we're going to talk about is iron deficiency anemia. Again, anemia is defined as a hemoglobin of 2 standard deviations below the mean for the normal population. So for our age population, which is where we're going to consider probably the highest at risk, is going to be those that are between 1 year old or 12 months to 35 months or 36 months. And so we're looking at the number of 11. So that's something that I want you to be aware of when you're actually drawing your or getting your hemoglobin at the 1 year visit and again at the 2 year visit. So iron deficiency is insufficient iron. And then therefore what we see with that is a decrease in iron stores, which is what you see with serum ferritin, a decrease in serum ferritin. And your iron deficiency anemia is a result of the iron deficiency. So what we'll see with children is numerous risk factors to be aware of would be prematurity, exposure to lead, exclusive breastfeeding without supplementation, weaning to cow's milk, feeding problems, and occasional special health needs, and those that come from a low socioeconomic status. I'm just going to back up for a minute just so we have an understanding. From birth to 12 months, 80% of the iron in infants is accreted during the 3rd trimester. So therefore, those that are premature will see that they're going to have a deficiency in their total body iron. So that's something to really, that plays a part. And you'll see many times those kids that graduate from the NICU will be on iron supplementation when they come into your practice. We see definitely a lower percentage of iron deficiency anemia, but we see a fair amount, and that makes sense in terms of iron deficiency. And one of the reasons why we're seeing a decrease in iron deficiency anemia is because we now have iron fortified formulas and foods, and then WIC that plays a significant role in providing education on proper nutrition and also decreasing the use of whole milk. So physical findings, mild, you may not see any at all, and moderate to severe, hopefully you're not seeing these signs and symptoms, but occasionally, if you don't catch them early, be poor weight gain, pica, pallor, splenomegalia, tachycardia, and flow murmurs. So those are things that we will see with moderate to severe. So what you'll see on the peripheral smear is hypochromic and microcytic cells, and that's what you're seeing here on the smear. So we have a CBC with a low MCV and a high RDW, and as I said, things to remember, it would be hypochromic and microcytic. We'll see low ferritin because those are the assessments of our iron stores, and we'll can also see a high total iron binding capacity. So again, we're looking at that number of our hemoglobin to be between 10 and 11. Our strategies and treatment, to know that it's truly iron deficiency anemia, we don't have to do a lot of lab testing. We don't even really need to do the CBC. If we get a history of poor nutrition, low iron intake, and we get a hemoglobin of 11, then we can basically surmise that it's nutritionally based. So we can actually start either changing the diet or changing the diet along with supplementation. And our supplementation is going to be elemental iron, and usually you only need 3 milligrams per kilo per day. And you can do that in 1 or 2 divided doses. Again, also education on nutrition would be to emphasize those foods that are high in iron. You want to recheck the hemoglobin in 1 month and continue to treat it until it's normal, and then you're going to give 1 more month of iron. Now, if we can just increase the hemoglobin with diet, that's fabulous, because iron is tough on the tummy. Black stools can cause some constipation, and many times parents will just stop giving it and they're not compliant with it. So we really need to stress that diet is the most important factor. So again, I'd like you to look over prevention in terms of your supplementation with the different foods, and also supplementing with iron depending upon those infants that may be exclusively breastfed versus partially breastfed. Again, for those older children, most important things would be limiting the amount of milk that they're getting per day. Because what children will do is they'll drink the milk or drink lots of fluids and not then eat, and therefore will be reducing their ability to gain iron through the fortified foods. So those are the important factors that we need to stress to families. I'd like to move on to lead poisoning. However, it will be brief because we really talked about screening already and testing and when we do that. But one of the things we want to be able to do is to identify those kids that are at highest risk for lead poisoning and talk briefly about what we do in terms of treatment. So if we look historically, we saw in 1991 about 1 out of 11 kids with elevated blood lead levels of greater than 10. And then really what the biggest concern is the long-term effects. And those, because they have very few signs and symptoms of lead poisoning, we have these kids that are walking around with high lead levels and eventually developing learning disabilities, behavioral problems, occasionally seizures, coma, and sometimes death. It's devastating. We know that it wasn't until 1978 that lead was banned from paint in homes. So therefore, there was a big move to take all the lead paint out of these homes. However, when you're taking lead paint out, you have to be careful because of the dust and the paint chips that can get into the soil. So those are issues, along with also water pipes, lead pipes can also leach the lead into the drinking water. And occasionally we still have some toys that are made internationally that have lead actually in the paint or in the plaster. So again, everything goes into the child's mouth, and then therefore that's where we see the increase in lead. So we see this little one here kind of chewing on the windowsill, looking out the window. Kids that are at highest risk is going to be between 1 and 3, although kids under 6 years of age we see most often for those that have lead poisoning. Again, as we said, everything that goes into their mouth, and therefore just chewing on the windowsills, paint chips, all of those things increase the risk for lead poisoning. So this just gives you a picture of some of the things, exposures to lead for a child. And again, these are all issues that, again, over a period of time, cause a change in the red blood cells and limit their ability to carry oxygen to organs and tissues. So again, our long-term effects can be developmental delays, speech and language problems, poor muscle coordination, issues with nervous system and kidneys, decreased bone and muscle, and sometimes occasionally seizures and unconsciousness. So this again just gives you some signs and symptoms of lead poisoning. Again, it's much more difficult in children because they don't come outright with these types of symptoms. They may not complain of headache, irritability, it's kind of hard to assess in a younger child, reduced sensations. So, these are all things that may be more difficult to pick up. And the reason why it's so important to do the screening and the testing that we do in primary care. So let me go back here. So again, specific for kids would be sluggishness, fatigue, pallor, metallic taste in their mouth, but they're not going to be able to usually describe that. Muscle and joint weakness, that's going to be difficult. Irritability, kids get irritable. Pica is one of the things we do. Sometimes we'll pick up lead poisoning with a kid where a parent says that they're eating dirt, chewing on ice. That would make us more suspicious. So the question is what age do you conduct universal screening, and at what age do you perform a risk assessment? So again, most likely this will be on your test. Universal screening is done at 1 and 2 years of age, and that's required for all Medicaid eligible children. And then a risk assessment is done at 6, 9, 18, and 3 to 5 years. And if there is a positive or a don't know, then they need to be tested. So management of lead levels between 10 and 14, we do education and environmental controls. People can go out into the environment and identify where the lead is actually coming from 15 to 19, again, diet and environmental controls, and that needs to be repeated in 1 to 3 months. When we get up into the levels of 20 and 24, it usually requires some further environmental investigation. And we usually, at that point in time, get the health department and other services such as neurodevelopment for the child. We get all of those things involved, and occasionally we'll even admit the child to the hospital and require chelation. Now, chelation therapy is usually reserved for the higher lead levels. However, depending upon the child's signs and symptoms, we may see that a bit earlier. Luckily, we don't see as much lead poisoning as we used to in the past. So prevention, again, most important is for parents to make sure that children are not having access to peeling paint. Children and pregnant women should not be in houses built before 1978. That's undergoing renovation. And barriers around any kind of lead sources. Make sure that parents are washing the children's toys in their hands. Again, everything they touch, it can be dusty, put it in their mouth. Again, that's where they can also ingest the lead. So these are just some